Okay. So, hello everyone. Welcome again to our session today as part of the CUGH conference. So we're very happy to be taking a project coordinator at the Global Health Institute at the American University of Beirut. And I will be moderating this session, so the first and second panels. So we're set to present and discuss two initiatives led by the Global Health Institute at the American top health research content and happens for today's and the capacities. So the academy. Hello. Am I back on?
Yes. Yeah, it's better now.
Okay, so where did I cut off? Yeah, I'm sorry about that. Where did I cut off?
If you can start from the intro again.
Okay.
Yeah.
So we'll go over it again. So hello everyone and welcome to our session today as part of the CUGH conference. So we're very happy to be taking part of this event. Again, my name is Hadi and I'm a project coordinator at the Global Health Institute at the American University of Beirut. And I'll be moderating the session. So we're set to present and discuss two initiatives led by the Global Health Institute at the American University of Beirut on the topic of gaps in research settings, and with panels scheduled. So with the first panel, we have three speakers that will present to you some of the work that we've been doing under the Center for Research and Education in the Ecology of War, which is also known as CREW, given as part of their involvement with the program and different capacities. So CREW is a capacity building program under the Academy Division of GHI, which was launched in partnership with the Swiss Cross Foundation, and which aims to equip frontline health workers with the skills and knowledge to conduct health research in the ecology of war. So you'll learn more about CREW and about its activities when we get to our second speaker. But let's first hear from our first speaker, Ms. Rania Mansour, who was a researcher on our team and who will present a scoping review that she led on the topic of health research capacity building in fragile settings. And then we can move to a 10-minute Q&A afterwards. Rania Mansour is a global health researcher, humanitarian advocate, and aspiring physician, currently completing her medical degree at St. George's University of London. Her research and professional activities focus on enhancing delivery within low resource and fragile settings. As a researcher, she explores the ethics and impact of global medical missions, the implications of human rights-based approaches to health program development and delivery, and the role of research capacity strengthening on improving healthcare indicators. Rania's varied skill set has enabled her to work at the international and community level in a number of countries, most recently in Lebanon with GHI. Her professional experiences include developing a women's health program in a refugee camp, advising the World Health Assembly on improving access to quality health data during emergencies, and advocating for the prohibition of violent attacks against healthcare facilities at the UN Human Rights Council. Rania has also worked on the amendment of global medical policies at the World Medical Association, and she's graduated from the University of Toronto with an honors Bachelor of Science. She completed her Master's of Public Health at the University of Pennsylvania Perelman School of Medicine, and she aimed career. Are you able to share now?
Yes, okay, hi. Hi everyone, my name is Rania. I am going to be sharing my screen with you right now. Can everyone see the PowerPoint? If you can confirm with me. Okay. Okay. So first of all, I'd like to say, all right. All right, so I'm going to get started. First, I'd like to say thank you, Hadi, for that kind introduction, and thank you everyone for joining us for this session. As Hadi mentioned, I'm going to be discussing a scoping review that we have conducted at GHI. It is on health research capacity building of health workers in fragile and conflict-affected settings, and it is currently under revision, which is very exciting. Your feedback is most welcome. So a little bit of context, and I know my colleague Tarek will be talking about CREW and what it involves, but some of the questions that are important to answer in fragile and conflict-affected settings are, what kind of health research is being conducted? Is the current data adequate to improve the public's health? What is the role and how can we use frontline healthcare practitioners to improve health research, and how health research can be optimized in such settings? So before I get started on to how we conduct the study, the methods, and our results, I just wanted to go through defining a few terms. So health research, pretty easy to define. I believe it's just research that focuses on health-related topics. This can be from the methods, such as qualitative or quantitative, to specific topics within healthcare, such as mental health trends and epidemiology. So fragile and conflict-affected settings, which I will from now on say as FCASs, just because it's a lot easier to, instead of saying the entire thing. So these are defined by the World Bank. And so the World Bank has 3 categories for them for such settings. The first is high intensity conflict. And most recently in 2021, there's 4 countries under that heading, and examples are Afghanistan or Libya. Second group is medium intensity conflict. So this involves countries such as Nigeria. And third category is high institutional and social fragility, which does not necessarily mean that there is, physical conflict, like a war is currently going on, but there is, it is a fragile state. And those countries include Lebanon, Kosovo, things like Eritrea, countries like that. So why is health research needed in fragile and conflict-affected settings? Why is it important? Well, we know that health research allows us to generate evidence, and this evidence is often applicable to a specific population, so focusing and tailored to a subset of a population or a population at large. And it aids in the development and delivery of policies and interventions. So putting this together, by conducting health research in fragile settings, we're able to generate evidence that focuses on a population and allows us to deliver interventions and policies that are tailored to them. So what is the situation of health research in fragile and conflict-affected settings right now? What is it like? Well, we know from research that health research in FCAS is increasing. More people, more research groups are being involved in the humanitarian sector. However, we also know that expertise and funding is driven by high-income countries to low-income countries. And a paper in the Lancet has actually likened this to a potentially neo-colonialist model of global health. By doing this, are we empowering high-income countries to have, different power dynamics in low-income countries? But another paper had also mentioned that there are relatively low authorship rates of individuals, of researchers coming out of low-income countries. So although 92% of global health articles address interventions in FCASs and LMICs, only 35% of those authors are from such stated LMICs. So this again kind of tells us about the power dynamics involved in these countries. And lastly, there is a stark difference between who is funding and who is experiencing the challenges in FCASs. And a few papers have discussed the impact of this discordance. And these include the implementation of temporary solutions rather than long-standing solutions that can be sustained. So the interventions end up being unsustainable or have the potential to be unsustainable. Sometimes the interventions or policies that are proposed lack local relevance because they are being driven by high-income countries. And if the funding does come from high-income countries, there is a potential that the interventions, the goals of the research mirrors the interest of those researchers and not necessarily those in the FCAS. So why is this a problem? Why is health research a problem in FCASs? Why is it being driven by high-income countries? Well, we know that a lot of countries in FCASs lack qualified staff and institutions. So as an example, the Global Health Institute at AUB is the first in the region to tackle global health problems, and it was only founded in 2017, so it's relatively recent. Even though we know that the Middle East is ridden with conflict for decades, and yet we have not had that the qualified staff and institutions to actually work on these things. Second, we know that FCASs suffer attacks against healthcare. There was a report just a few days ago actually indicating that in 2020 alone, more than 800 attacks against healthcare were happening globally. And a part of that was related to COVID-19, but also because we know in fragile and conflict-related settings, healthcare can be presented as a target. We also know that FCASs face demanding population needs. So not only are they, struggling with infectious diseases and non-communicable diseases, but the symptoms and the clinical presentation of health issues in FCASs is unique, whether it is, just focused on like bullets in a certain conflict setting, or it's respiratory diseases due to the population of a post-conflict setting. And we know that FCASs often operate under a fragmented healthcare system because of the inherent issues of the country. It takes a while for a healthcare system to overcome conflict, social and financial fragility. So this is why fragile conflict settings present with a health research problem. So a mechanism, a part of the solution to improve health research and to improve the public's health in FCASs is health research capacity building. And I'm not going to try to define it myself, so I'll use definitions from the World Health Organization and the UK International Development Group. So it says that novel mechanisms are HRCB, so health research capacity building, is a novel mechanism aimed at enhancing the abilities of individuals, organizations, and systems to undertake and disseminate high quality research efficiently and effectively. So I'd like to just take a moment to highlight the fact that it's discussing individuals, organizations, and systems, and not simply individuals. So we're providing, the aims of HRCB is to provide research skills to everyone across all levels that would be involved in research. Now, my team proposes that there's a unique population that has the capability to use and to, optimize and capitalize on HRCB, and that is health workers. So the World Health Organization divides health workers into health service providers, which are clinicians that work in hospitals and nurses and assistants, things like that. And then there's health management and support workers. And these are the people that are often behind the scenes. They can include individuals in the Ministry of Health and management roles, but also in logistical roles, individuals that are monitoring vaccines and calculating the numbers, and researchers a lot of the time. So by equipping health workers with health research capacity building opportunities, they're not only learning how to conduct research, they can also be trained and they develop skills. They can receive proper coaching and the adequate knowledge in order to conduct research and understand how to best improve health within their communities. So why is HRCB important in fragile and conflict-affected settings, even though it seems like a pretty obvious answer? Well, health research capacity building identifies and tackles local health problems. So if individuals in those settings are tackling local problems and identifying them, this also means that HRCB is important to encourage local funders and policymakers in order to invest in the solutions that are driven by their health research. And of course, it would promote long-term sustainable solutions, which was one of the problems that we discussed earlier in having health research being conducted or primarily driven by high-income countries. And we know that this works because there are a few examples of such programs, and these include CRU, which my colleagues will talk about. It includes the R4HC MENA, so research for health in conflict settings, and as well as the CDC's Field Epidemiology Training Program, which has been going on for 40 years, more than 40 years now, and equips individuals in conflict and humanitarian settings with the research needed to collect epidemiological data. So we definitely know it works. So what's missing? What do we not know? Well, we don't know the characteristics of the specific HRCB activities happening across FCASs specifically. We don't know what they entail and what are they like at the current moment. We also don't know what the challenges and successes are. We don't have a concrete understanding of that. And we haven't developed as a global community recommendations that are evidence-based and also based on our experiences. So these three things, these 3 points became our aim, became our objectives for this research project. And our research aim became to examine current literature on health research capacity building in fragile and conflict-affected settings in order to map the initiatives and identify gaps and opportunities. In order to do so, we conducted a scoping review, and a lot of people ask why scoping review? Well, for the interest of time, that is one thing, and the fact that we wanted to incorporate our findings in the CRU programs and within GHI, but also because we wanted to explore the type of evidence overall. We wanted to understand the extent of the work in this given field, what are the gaps, and to synthesize the literature to guide future work by research mapping and data charting. So we used the PRISMA framework specifically for scoping reviews, and our first step was to develop search terms. So our population of interest was health workers. Our context was FCASs, which were defined by the World Bank, as I've explained before, and our outcome was having an initiative, a health research capacity building initiative with specific outcomes that we can learn from. So we searched 4 different databases using our keywords, and those are Embase, Cochrane, Scopus, and Sinal. And our exclusion criteria were 7. So first we excluded papers that were not original research or peer-reviewed, I should have stated here. So any commentaries or abstracts, although they do provide us with rich information, having a peer review process is extremely important. Second, outcomes that were not about capacity building programs were also excluded. Interventions not related to health research. Participants not being health workers, so let's say undergraduate students. Setting not an FCAS, language other than English. This was definitely can be considered a limitation because it would have been nice to be able to take papers that were written in different languages, but limitations of our research team hindered that a little bit. And papers prior to 2010. So our HRCB is a novel field, and there actually isn't much research prior to this. Plus, we wanted something that is very relevant that we can use with the current conflicts that are ongoing. So this became our PRISMA diagram for all you researchers out there. So we started with upwards of 17,000 papers, and through an extensive exclusion process, we ended up with 20 papers that are included and analyzed in our scoping review. So our data charting, our collection process was based on a database that we had built before, collecting all our articles, and we wanted to look for specific things. So the first thing was the bibliography, was really the authorship or data regarding publication of the paper. So who is the author, from what country, what are the corresponding author affiliations, so their institution, the study design that they used, and their funding organization as well. Then we looked at the intervention. So what was the population and the size, the program duration, 2 weeks to like months, years. What was the setting? Was it in hospital based? Because we are looking at healthcare workers, or was it in the community? the topic and the objective, what kind of health research were initiatives driven by, and what type of health research capacity building. So was it a workshop? Was it a fellowship, an academic one? Delivery modality, so whether it's online or in person or a combination of both, and as well as the evaluation approach, which I think is extremely important because it allows us to check and to understand the short-term as well as long-term efficacy of the programs. And the most important, which is what we wanted to learn from, was the outcomes. So what are the challenges that professionals experience? What are the strengths that they found within their HRCB interventions? And what are the recommendations that they put forth for the global community so that we can carry on? So our analysis of this data was two-pronged. So we did descriptive analysis of the study characteristics and the intervention, what topics were involved, who, the population, et cetera. And then we did a thematic sort of analysis of reported challenges and strengths. So I say thematic sort of analysis because we didn't go in depth in understanding why these were challenges. Rather, our goal was to chart this data. And so we used a mix of ARC's, O'Malley's, as well as Thompson-Hardin's qualitative approach. We did a line-by-line coding of the text, then developed descriptive themes, and then grouped them into categories that we had already mentioned, being challenges, strengths, and recommendations. So our study characteristics, I'm going to go briefly over this. Most of the countries involved were in Africa, so about approximately 90% of them. Research topics focused actually on health research methods. So most of them really just wanted to equip health workers with a method to conduct research, such as qualitative, quantitative, epidemiological. Target population, most of them were health workers. And study design, actually all of them were health workers, but specifically only health workers were approximately like 80% of them. And study design was mainly mixed methods report back. So this is a nice map showing the countries that were in these papers. As you can see, most of them were concentrated in Africa, as I had mentioned, and the topics pertaining to each country, pertaining to initiatives within each country, are also highlighted here. So our publication characteristics, corresponding authors, 75% were in the North, again, ringing the bell of North-driven or high-income country driven research papers. Collaborations, most of them were North-South. And here are statistics for the journal impact factor in which the papers were published. All right, so here's the interesting stuff as a qualitative researcher, the themes that we wanted or that we found. So under challenges, there are 4 distinct themes. So those were structural challenges, logistical, challenges related to personnel, as well as concerns of assessment and evaluation. Under strengths, they were locally driven, pedagogical considerations were taken into account, and having holistic capacity building interventions. And recommendations for future pertain to logistics of development and delivery of HRCB structural components, as well as content of the HRCB interventions. So from this point forward, I'm going to be providing quotes from the papers, actually, taken directly from them, regarding each of the sub-themes to try to exemplify what we meant or what is understood by certain challenges, strengths, and recommendations of the HRCB interventions. So let's start with challenges. Under structural and systemic challenges, one paper noted that in this context, where research use culture is still largely underdeveloped, a great deal of attention should be given to the context, complexity, nuances, and interdependence of factors motivating behaviors. For example, in a country where decision-making is highly centralized, any influence exerted to affect change should not be limited to the local arena, but should definitely also focus on the national level. So here there's, we like to implement HRCB interventions and we want to say at or to health workers specifically, but as this quote mentions, FCASs have a research culture that is underdeveloped. And so targeting only health workers may not be the best solution moving forward. And it is a challenge because if the national level doesn't accept it or is not motivated to conduct HRCB interventions, then our work at the individual level may not be the most efficient, not saying that it isn't. So logistical challenge that were highlighted, one quote said that there are limited funding options for health research capacity strengthening in the Solomon Islands, and limited incentives for supporting capacity strengthening from less resourced countries. So often health research favors commercialized profit-building technologies. In resource-rich countries, it does not strongly support RCS in small, remote, or less resourced areas. And this, given that FCASs are fragile in conflict-affected settings, we can assume the limited resources and the limited funding opportunities that may impact the capability to implement an HRCB intervention. Third theme out of 4 for the challenges were the personnel challenges, and this was very interesting actually. So one of the studies said the challenges we noticed include different levels of acceptability of the program by individual faculty and research infrastructure, and lack of support by institutional leaderships. And it was kind of interesting because if we are really motivated to conduct HRCB interventions, but our leadership is not, it really limits the extent to which we can perform such. So this might be also something to target in the future in terms of getting individuals motivated on this track. And the last subtheme under challenges were assessment and evaluation concerns. So in terms of how can we evaluate the HRCB intervention? So one paper said that our evaluation was limited to proximal outcomes, such as confidence and knowledge, rather than more meaningful distal outcomes, such as publications, grants, career trajectories of participants, and change in policy or practice. And this is also interesting because it's true, right? So if we just consider the impact on individuals' knowledge and confidence, we won't know what the true impact, the long-term impact on their careers or on the future of health research in whatever context they are in. Another quote said, we were not able to include the views or observations of all members of the research team and healthcare workers involved in the studies. A major omission was the collection of views and opinions of community members, therefore not able to fully reflect. So another assessment concern was being able to collect data from appropriate stakeholders or all the stakeholders that would be involved in the layout or the playout of the HRCB interventions. So that were challenges. Now we will discuss our strengths. There were 3 subthemes under our strength, and those the first one was that it was a locally driven intervention. So one study said that RCS undertaken at this hospital, rather than having to leave the campus or the country, was identified as a benefit to both individual researchers and the institution. It allowed for strengthening of research knowledge and experience with a broad range of professional and community participants in the local context and using local examples. This allowed capacity strengthening while maintaining the operations of the hospital and College of Nursing. So just as this quote says, by ensuring that the HRCB intervention is locally driven by local individuals and taking local examples into context, they did not interrupt their work at the hospital. We're not taking individuals away from their normal day-to-day life. And this could have a huge impact on the equality of implementing an HRCB intervention in that setting, yet also not taking away from the setting, which is already well resourced. Pedagogical considerations was also a strength of most of the HRCB interventions. So one study said that respondents particularly appreciated the practical exercises, the discussions, and the trainer's interactive teaching approach. They offered many examples. He gave us ways of increasing membership. He prompted us to develop an action plan, and he coached us through its implementation. So here we can see a lot of respondents, the participants, really like the idea of doing something hands-on that they could implement in their day-to-day life. Giving a lecture is of course important, and giving them ideas on how to learn things or what to learn, but it wasn't as effective as actually doing and working in that field. Our third subtheme and last one under strength was having a holistic capacity building intervention. And the quote I chose, it's very interesting. It says that in some countries, the veterinary and laboratory sectors were included in training cohorts to foster local cross-sector collaboration and a One Health approach to surveillance and response activities. So in this case, I believe the training was regarding surveillance and epidemiological activities. And instead of just teaching them how to conduct that, they use data and they use participants from different sectors. And it really shows the importance of cross-sector collaboration and the fact that health is not only a, it's not that we don't work in silos in healthcare, and how important it is to work across different sectors. So our final theme was that of recommendations. So we wanted to know, what did researchers, after conducting HRCB interventions, really recommend, and what did they think we needed to focus on moving further forward? So first was the logistics of HRCB development and delivery. And I have a few quotes under this one. So one of the studies said the most common suggestion for improvement was to lengthen the duration of training. This is very simple. Lengthening duration of training allows potentially more exposure, allows more comfort with teacher and student, allows the individual to explore their training further. Another study said the extended work period will also provide students with a better chance to publish their findings. And here, you can take a sense that it's not only about training and allowing them to learn something new, but also how can it contribute to their future careers? How can it contribute to their professional profiles? And by having a chance to publish their findings, for example, we are doing so. Now, a third quote said, countries and many LMIC should encourage local funding towards research as a way to reduce dependency on foreign donor funding and increase research output. And just as a quote said, it's about trying to advocate for local funding for our research capacity building programs. So the second theme was structural components. So what is inherent to the HRCB intervention that must be improved or that could potentially be changed? One study said that it is our recommendation that future capacity building activities on the continent adopt a multidisciplinary approach, and that capacity building should be linked to the overall research agenda of the region. And this really ties nicely with the strength that I spoke about earlier regarding using cross-sectional fields. And of course, there are sustainable development goals that we have that the regions want to achieve. And so by putting them in line with that, I believe we're not only allowing funders to truly be convinced of our reasons to conduct HRCB interventions, but also it ensures that we're all working together in a multidisciplinary way. Another quote says, considering applying triangulation techniques to assess the impact on a broader group of stakeholders and considering additional outcomes. So in terms of trying to do assessment and evaluations, it is important to collect the data from different stakeholders, which, if you remember, I had mentioned as being a certain challenge. And the last recommendation opportunity pertained to the content of HRCB intervention. So one quote says, they also noted some points for improvement, such as the need to develop a concrete trial proposal as part of the workshop, to reduce the amount of material covered, and to allocate more time for practical sessions. Again, indicating the importance of hands-on work and practical work rather than just a lecture that they can learn from. Another paper also said that we recommend that the vehicle for delivering capacity building opportunities be a mix of formal academic degrees or fellowships, as well as the regular filling of gaps of knowledge through workshops to address expressed in areas of need in LMICs. Again, highlighting the practicality, highlighting the need to promote personal profile and professional profile through these settings, through these interventions. So what are our takeaways from this data? We know that the challenges can be summarized, or the most important challenges are those relating to the evaluation, whether it's a short-term and long-term, whether the capacity building program is individualized or on an organizational level, and then the sustainability of it. Does it last long-term? Does it allow individuals to continuously improve their health research and work over time? The strengths of a lot of the studies I had mentioned included that they included a needs assessment or an opportunity assessment to see what the community actually needs and wants to work on, as well as a context-specific design and being locally driven. The implementation of experiential learning programs was highly sought after, and having multidisciplinary participation throughout the HRCB programs. So these are the takeaways, but what are our observations as researchers who are involved in health research capacity building? What did we notice from the literature that we know of? Well, first, that the number of papers does not really reflect the number of health research capacity building initiatives that are actually taking place globally, because we only had 20 papers. And we know that NGOs prefer to communicate findings via reports, and they often conduct HRCB initiatives. So it does portray a lack of communication between humanitarian and academic sectors. Also, the countries and regions studied, we are in the MENA region, so this is of interest to us, and that it's been in conflict for years, and there was only one paper in the MENA region. However, it can't be at fault because most studies worked on, were in Africa, and this is influenced by the definition of the World Bank, where most of the countries that are considered fragile are also in Africa. 75% were led, 75% of the papers were led by authors in the global north. And this really highlights the power dynamics I was talking about earlier related to the funding, the colonial history, and the human resources and availability, which we know all may impact location of decision-making, and it can shape the capacity building intervention, as I had said in the introduction. However, we also know that the global north does host most institutions. So that's an observation to make. We also noted that, which is something that an upcoming topic, is a gender-sensitive approach to health research capacity building or any initiative that is being conducted in humanitarian settings. We know that women are disproportionately affected by conflict and fragility, and if we employ a gender-sensitive approach, it would help normalize gender equity, despite the cultural, social, political, and gender discrimination that may be in such settings. And we also know that our findings align well with previous studies in FCASs. However, one thing that is interesting is that a lot of previous studies have spoken about the ethics of the research conducted and whether it was ethical or not, which is not something that our papers touched upon. But this also might be because most of them were locally driven and involved, local context and local material. So what are, if we can have like 5 recommendations, for the future, what would they be? Our team tried to summarize them nicely. So first is that FCASs must allocate funding for HRCB programs. And this is to equip programs with the resources, to lead their own projects and reduce dependency on the global north. A second point is that our HRCB programs equip trainers with understanding of specific needs and cultural nuances of the local context. So in the case that high-income countries are being helpful and training individuals in FCASs, then having that specific cultural and local understanding is extremely important. It's also important for FCAS to design, implement, and evaluate long-term HRCB programs. So it's not just about putting it there, but addressing organizational, institutional, and systemic levels, in addition to the individual level, and to enhance the impact and sustainability of the programs by making them long-term and then knowing how to evaluate them for a longer term. HRCB programs also to develop and deliver local, regional, international partnerships. So let's say GHI, the American University of Beirut, partnering with other institutions, other NGOs, but also in different regions, such as working with individuals in neighboring countries, Syria, Palestine. And HRCB programs to be contextually relevant, as we've been stating all along, delivered using engaging and practical hands-on approaches. So not just going and teaching individuals how to conduct research, but actually helping them conduct the research that is relevant to them in the moment. So wider implications as I finish off this presentation regarding fragile and conflict-affected settings. What are things that we should be considering and what can our data help with? Well, we know that conflict right now, it's mostly protracted, and conflict is happening through proxy wars. So they're an average of 12 years long, and there's a high amount of human displacement. There's also shifting burden of disease, which causes different needs for different countries. And this is really shifting from a short-term humanitarian solution to, in conflict settings, to a long-term sustainable solution. And health research capacity building programs have the potential to help with that. Something else is implementing equitable interventions and partnerships. So although the Global North hosts most centers that are involved in research within FCASs, our data really shows that locally led initiatives resonate better with the local needs, knowledge, and the narratives of the people. And that's something that was a strength in the studies that we looked at. and the importance of strengthening local capacities at all levels. Although we know that automatically strengthening, one level will improve others, other levels, it is important to work on the spectrum. As an example, one paper had mentioned that in Aleppo in 2016, there was massive brain drain because most of upwards of 95% of the health workers had to leave. And if we're only targeting the individual level, then we're leaving a lot of missed opportunities, which could be important to provide accessible infrastructure, reliable data and databases, and to provide permissive environment to work with health research. So with that, I'd like to have some considerations of our study, and feedback is of course more than welcome. But health research capacity building is a novel field. It's our searches and our data is influenced by inconsistent terminology, such as the difference between capacity building versus capacity strengthening. We did not include also gray literature, and we had a small sample size of 20 articles. So these are limitations, although our data is pretty rich, I would say. And so with that, I'd like to acknowledge my co-authors, Hadi, Tariq, and Layal, and Dr. Zassim, and Dr. Shadi Saleh, and our interns, as well as our financial, International Development Research Center for financial support. So thank you very much for listening and bearing with me through all of that. If you have any questions, I am hopefully ready to provide some answers.
Thank you very much, Rania, for this interesting presentation. So yeah, the findings are definitely an important addition to the field, and they also help, set the context for the crew model, which my colleague Tariq Shawi will discuss shortly. It's also worth mentioning that this paper is currently under revision and should hopefully be published sometime soon. So, okay, so now we will open the floor for questions. So everyone, please go ahead and type them in the chat box if you have any, and I will relay them to Rania. Do we have 3 so far? 2. Okay, so we have Amit from NIH. It's a comment. They say, excellent presentation. Our group at NIH commissioned a collection of case studies of research and humanitarian crises that might be of interest. They shared the link, and the collection also identifies some of the challenges and strategies for research in FCAS. Thank you very much.
Thank you very much.
Okay, we have Bernie from PLAS. Thank you for the excellent and enlightening presentation. What are your thoughts on the role of scholarly publishing organizations or journals in supporting health research capacity building in FCAS? And is there a place for scientific journals to bring to the table relevant sustainable solutions that could enhance health research capacity building in these settings? Would you repeat the question?
I think I got it. I think I have them also here. I'm trying to find them on my screen.
Okay.
Yeah, that's actually a very good point. I was at a conference last year that discussed the idea of open sharing of knowledge and having open access of research, and the importance of that, because if you conduct health research capacity building interventions and publish them in open access, then a lot more research groups and individuals can access that data and work from there. And I think that is extremely important, something to push forward, because I know now a lot of journals that are open access require you to pay. And if we're already talking about low funding and low resource settings, that might be difficult. So I do think that publishing organizations definitely have the capability to, to push forward the work that's being done, and to really, advertise or advocate for this work to be done and to be exposed to a lot of people. So they have that role. And another role I think that publishing organizations can do is set out certain journals have, monthly themes or yearly themes that they'd like to include. And if HRCB interventions is something that they're interested in and they use that as a theme, it could be very helpful and encourage a lot of researchers to work on this field. Yeah, I don't know what, please welcome also answers from my co-panelists today.
Yeah, I think you got it there. I don't have anything else to add to that.
Yeah.
Okay, so we have another question from Catherine. Thank you, Dr. Mansour, and congratulations to you and your team on the fantastic work. Are you able to read the question? I'll just read it out loud.
Please, yeah.
So yeah, congratulations to you and your team on the fantastic work. What are your thoughts on engaging high-income country researchers and/or academic medical institutions with healthcare clinicians and healthcare workers on the ground in FCASs and conducting real-time research data collection in a mutually beneficial manner? And then how can those on the ground in FCASs gain increased acknowledgement for their contribution to research?
Okay, so okay, I'll try to tackle these one at a time. So the first is, I'm just going to repeat it again, on engaging high-income country researchers and conducting real-time research on the ground in a mutually beneficial manner. I think this is a very, okay, theoretically, hypothetically, it could be a very easy solution of simply asking if they need that help and if they want to do this work, and splitting the tasks evenly in a mutually beneficial manner, like you stated. But one thing I like to mention is the idea of conducting a needs assessment. And I'm actually liking to call it opportunity or asset assessment lately, because a lot of times there are many opportunities to conduct research in these settings. And if we look at it in that way, we're actually empowering the communities themselves to figure those out, to understand where can we collect this data and how can we do it by ourselves and for ourselves. And so it's definitely possible, definitely splitting the work, definitely allowing for intellectual contributions from both ends. And that is definitely, a solution. In terms of the second question, how can those on the ground increase acknowledgement of researchers in FCAS? Well, something we mentioned was the idea of corresponding authorship. And that's often, if it's delivered by high-income countries, it could be, the corresponding author could be in a high-income country, but also through first authorship, or providing them with the responsibility to conduct the research on their own and come up with their own methodology for conducting research, for example, including them in the research findings, have them present research at conferences, things like that could really, and empower them to further develop their work and their professional profile in order to, and these are ways in you can highlight their contributions in research. Any more?
Okay, great. Thanks, Rania. We have one more question, and this is the last question for this talk, just so that we can keep to time and take into consideration the rest of the speakers. So we have a message from Ella. She says, to follow up on the comment from Dr. Odeni at PLAS, I'm just finishing a systematic review of writing and publishing interventions in low and middle income countries. One of the themes that emerged in the lessons learned reported in these papers was the need to provide funding for researchers to both access the academic literature and to publish an open access agreement. So do you have any comments on that, Rania?
Yeah, actually a quick comment. One of the papers had also mentioned that a way in which high-income countries researchers could help was by providing funding to access research. It's very interesting. It sounds like a very interesting paper, Ella. So I look forward to reading that and knowing more. It's definitely something that the publication community could definitely work on.
Okay. Thank you. Thank you very much, Rania, again for the presentation. So we will move
Thank you.
to our next speaker. So our next speaker is Mr. Tariq Kishawi. He's a colleague of mine also, and he is the primary coordinator for CRU. So again, CRU is the Center for Research and Education in the Ecology of War. So Tariq Kishawi is a consultant working in curriculum development for the Global Health Institute's Center for Research and Education and the Ecology of War. He earned his undergraduate degree in history from AUB, the American University of Beirut, and he completed his postgraduate studies at the University of Sheffield, earning a master's degree in public health. He has worked in community centers, providing vital services and assistance to migrants and refugees in Lebanon and Greece. His main interest is to transform local expertise and knowledge in the MENA region into institutional knowledge production as a means to challenge and shift the global balance of power. His main research interests include the study of war, infectious disease, antimicrobial resistance, and health. So, Tariq, very happy to have you with us. The floor is yours.
Thank you, Hadi, and thank you, Rania, for that excellent presentation. You should all be able to see my screen. So, as Hadi mentioned, I'm going to be talking about CRU, kind of as like what a health research capacity building initiative could look like. So I'm going to discuss kind of the background of CRU, how it came to be, and what was the rationale for it. And then I'm going to talk about what were some of the challenges and that we faced. So to begin with the rationale and the context, we all know that that health outcomes are shaped by inequality. So within countries, there's a lot of work and research been done on the social determinants of health and how those influence health outcomes. There's also a growing literature and growing research on how health disparities exist globally. So we know that that there are quantitative health disparities across the globe. So for example, maternal mortality or infant mortality is much higher in lower income countries than in higher income countries. But the difference is not only quantitative, there's a qualitative difference in health outcomes across the world. So the types of diseases and the types of health issues that are faced by lower income countries can be very different than in higher income countries. So for example, infectious diseases are much more burdensome in LMICs, although now with COVID, it's kind of leveled the playing field in a way with infectious diseases and has recentered infectious diseases as a major health challenge across the world. But nevertheless, infectious diseases remain to be very strongly connected to power dynamics and power imbalances. For example, neglected tropical diseases, HIV, TB, continue to be much more burdensome in lower income countries than higher income countries. And if we want to speak about our region specifically in the Middle East, MENA region, the burden of war and traumatic injuries remains to be very high. Our region, as Rania mentioned, has been experiencing war since at least 1948. I'd go even further back and say that we've had a century of war ever since World War I, followed by the colonial wars, and then all the wars that have happened since the 40s, 50s, and to our days today. And this imbalance, this inequality is reflected in the type of research that is done. So not only is there more research being done in high income countries, But the focus of the research that is done across the world, because it's centered in high-income countries, tends to favor or tends to be skewed towards health issues and research topics that are priorities in high-income countries and may not be such a high priority in lower-income countries. So burdensome diseases in low and middle-income countries are deprioritized, such as infectious diseases. Whereas in higher-income countries, the research that is conducted is more focused on diseases that are either commercially profitable. So, for example, a large number of studies, a disproportionate amount of studies is done on dermatological disorders or illnesses, or on dermatology in general, even though skin diseases do not have such a high burden in high-income countries, but it's profitable because of the cosmetic industry to do research on this subject. So we
Nope.
Sorry, I think I may have been disconnected. I'm going to try to jump back to where I left off. There is an imbalance in what health issues are prioritized in high-income countries and in lower-income countries. So just to put some numbers to this issue, this chart displays the gross expenditure of research and development across the world. So if you see high-income countries altogether spent close to 1.5 trillion dollars.
I'm sorry to cut you, Tariq, but can you please share screen again, because we lost the PowerPoint presentation. Thank you, and sorry again.
Okay, sorry. Oh, sorry. Let me just do that real quick. Okay. I think you should be able to see my screen now. If not, just stop me. Okay, we can see it now. Perfect. So this chart shows the gross expenditure of research and development across the world. This data is from UNESCO, and it's from 2018. So as you can see, high-income countries collectively spend about 1.5 trillion US dollars on research and development in 1 year. This is in 2018. Whereas lower and middle-income countries spend about 100 billion. So it's magnitudes, orders of magnitudes less than in high-income countries. And in fact, if you combine all lower middle-income countries plus China, you still have lower dollars spent on research than just the United States. So all LMICs, which encompasses 35 countries, plus China, spend less than just the United States on research and development. So we're talking about major disparities in research and resources allocated towards research. And even if you look at this as percentage of GDP expenditure on research and development, the disparity is still just as much. So for example, LMICs spend less than a fourth of their percentage GDP compared to higher income countries. Major disparities. So this kind of informed the rationale for why it's important to strengthen research in our region, particularly on the issue of conflict, since conflict and war have such a high burden of disease in our region. So really the idea for CUGH after after a conference was held at AUB in 2016. It was called the Conflict Medicine Conference. And it really it sparked a debate and the discussion on the lack of reliable data coming from conflict settings. And what little data existed usually came from military sources, American military sources. So the impact of, for example, depleted uranium on populations in Iraq, a lot of the studies on that comes from the US military. Or for something that I'm going to be talking about more, the relationship between AMR, antimicrobial resistance, and war. Many of these studies also came from militaries. So not only is the data scarce, but what little data exists really comes from the point of view of military medicine. And the concerns of the military is very different than what the concerns for the general population will be. The military is interested in making sure their soldiers are healthy and safe, and that their injuries can be treated and that they can be redeployed in the battlefield. Whereas the long-term impacts of the war aren't really a concern of the military. Their concern is really about their own soldiers. And this is a trend that we see throughout history. So for example, the study of malaria and infectious diseases were first started by colonial countries to kind of either ensure that that their supply chains could be maintained, that the workers in their colonies could continue to work, or that their soldiers garrisoned in the colonies could avoid malaria, for example. And there's books and papers, historical and anthropological papers written about this extensively. So to come back to CRU, our basic premise is that CRU is that conflict and war can be seen as endemic to our region. Since it's been occurring for the past 100 years, conflict and its associated health complications and health impacts can be seen as endemic to our region. So we really need to address it in a radical way, in a really holistic and all-encompassing way. And to do this, we deployed, or we employed a theoretical framework developed by Dr. Omar Dawashi, who's at the University of Rutgers. He's a Iraqi medical anthropologist who coined this term, the Ecology of War framework. And what this framework really says is that a war has such a drastic impact on the entire ecology of a place that it cannot only be limited to, say, the biological injuries that happen, so we cannot only look at conflict medicine as studying blast injuries or war wounds. We really need to understand that war influences the entire ecology. It influences the psychology of populations. It influences the economic relations of a place. It causes huge migration patterns and population movement across borders. It even can influence the microbiology of an environment. And really, I want to stress on the importance of this thing, of how war can influence the microbiology of an environment, because our research focus for this year in CRU was antimicrobial resistance. And what we have come to understand, not only through the studies that our fellows in CRU have conducted, but also other researchers have shown how war itself and effects of war can be drivers of antimicrobial resistance. So they can cause bacteria to become more and more, or less and less susceptible to antibiotics. And the Ecology of War framework can be applied to other aspects as well, especially, for example, mental health. So if we want to really think about how PTSD is affected by war, we really find that it causes, generational impact in terms of trauma and mental health. But this can also be applied to cancer, to any kind of other NCD. And so what we really focus on in this Ecology of War framework is addressing these health issues from a multidisciplinary approach, combining anthropology with public health, sociology, and economy. These things are all connected if we really want to understand the full impact of conflict on public health. So I'm going to talk about a little bit on actually what the CUGH model is and how it was implemented. So the Center for Research and Education in the Ecology of War, CUGH, our flagship project was this fellowship program. And this fellowship program, what we aimed to do was to recruit frontline health workers working in conflict settings, and work with these frontline health workers through a training program in which we train them in research methodology, quantitative, qualitative methodology, as well as statistical analysis. And we give them also a training on this Ecology of War framework. And the speaker who will follow me, Dr. Reem Abu Shomar, she was a CUGH fellow, and she'll be talking about her experience in this fellowship and what it looked like for her. So I urge you to hang around to hear her perspective. And so after they complete this training for 3 weeks, we pair them up with mentors who are experts in this field. In this year's fellowship, all the experts were infectious diseases experts, since the research was done on antimicrobial resistance. And so we had mentors from universities around the world, in Canada, in the UK, as well as in Lebanon, paired up with these researchers and kind of guiding them through the field research process. After they collect their data and analyze it, we work with the researchers to write up a manuscript, and we then we will disseminate their research through journals and conferences, as well as policy reports. The point is to get this research disseminated so that it can, influence policy and inform healthcare workers and inform health practice. So some of the successes that we had in this project is that we proved that this model is feasible and it's desirable. Some of the fellows that we had worked with, this was really, although they had gone through formal education and many of them had been practicing in the field for many years, for some of them this was their first time engaging with a rigorous research process. The fellow Reem, Dr. Reem Abu Shomar, who followed me, she's an exception to this. She had a background of research, but still was able to attend and to learn new things from this project. In addition, the mentorship component of the fellowship exposed these researchers and these practitioners to mentors who could not only guide them through this particular research project, but who, in the best of circumstances, were dedicated to their academic and professional development, and kind of exposed them to new networks and open new doors for them to be able to progress through their careers and their academic research possibilities down the line. And another strength of CUGH is the evaluation component. We had a rigorous evaluation component throughout all phases of the project. We collected data about how the fellows learned the concepts of research methodology using pre and post tests, but we also had a lot of qualitative data collected throughout the research process. We continuously asked fellows to share with us what are some of the successes and challenges and difficulties they're facing in doing their research, so that we can learn from this experience and kind of build on it for next year's or for the next cohorts of researchers that we aim to recruit in the future. In terms of challenges that we faced, really the challenges are by and large structural challenges connected to resources and really structural issues that our region face. So the number one, I would say, or one of the biggest challenges we faced was a challenge that almost everyone living in our region faces, which is mobility. Our region for the past 100 years has been heavily militarized, and our borders are reflect that. It's near impossible for some academics and researchers working in countries throughout the region to travel across borders and meet other researchers and attend conferences and attend trainings. So just from our example, in CRU, we had one fellow from Gaza and Palestine who was supposed to be attending our training. And unfortunately, she was denied travel permission by the Israeli occupation authorities, and she was not able to attend this training. Another one of our fellows, and this is before COVID. So these travel restrictions were there, and these travel difficulties were there even before COVID. Now everyone kind of has the taste of what it's like to have such stringent border policies, but for most of the world, this was the nature of travel even before COVID. Another one of our fellows from Yemen, in order to come to Beirut, where the training was, he had to fly on a UN flight from Sana'a in Yemen to Djibouti, and from Djibouti to Turkey, and from Turkey to Lebanon. So really, it's an odyssey just for him to come and attend this one training. We also had another fellow who was supposed to attend, but we had to rescind his, we were not able to attend because he's from Syria and he works in a Syrian hospital, and due to US sanctions policies, we were not allowed to provide him with this training. So these are really, as I mentioned, structural issues. In addition, there are obviously funding limitations, time constraints, and so although we received generous support from our partner, from Swiss Cross, this is really kind of, if we really want to look at it in the grand scheme of things, a drop in the bucket for what is really needed to shift the balance of research production around the world. Because really what you need for large-scale research is government funding. You need your local government to give you millions of dollars to be able to invest in education, invest in academia, so that you can really build this research infrastructure. But what we hope we can do with CRU is offer a model that can be replicated, and really to focus the efforts on building local capacities and local strengths. So in the previous, my previous panelist, Rania, someone asked a question about this, what if we can pair up researchers in high-income countries with researchers in LMICs and have the LMICs work together and kind of and divide up the tasks in a fair way. In theory, this to me, in theory, this sounds good and it sounds doable and really has the potential to really have these transnational collaborations that can be equitable. But what ends up happening many times is that researchers in LMICs or FCASs end up just being seen as data collectors. And what ends up happening is we have this extractive model of research where we have institutions and academics in high-income countries coming in to low-income countries and really extracting data, profiting from this data by advancing their careers and by publishing, and without really centering the research priorities of the local society. So what we really want to advance in CRU is this idea that local actors should set the agenda, the research agenda for local issues. The agenda should be set locally. The research should be done by researchers working locally.
Seems we lost Tariq. Tariq, you're back.
Once more, I think you can see my screen again. Yes, I'm back. I'll just move on to the next slide. And so our outlook for the future is to have CRU become fully online. Although there is something to be gained about the face-to-face interaction, we believe a benefit of having it fully online, not only because of COVID now, it's really the only feasible way to do it. And online education has kind of become the norm, but because it really helps us overcome a major challenge, which was the mobility challenge. So by having our training done fully online, using both synchronous and asynchronous learning, we can have a fully immersive and engaging training done fully online without having to bring in fellows and researchers from countries that are difficult to travel out from. Hopefully in the future this can change, but I think for right now, having it fully online is the way to go. For the future, we want to introduce new thematic topics for research, such as cancer. We find that there's really limited understanding of what the cancer landscape looks like in conflict settings, what treatment is like, what the burden of disease is like, what are some of the main drivers of cancers in conflict settings. There's a lot of research that needs to be done there, and we will of course continue with what we have with AMR research. We want to build on the research that's being done right now. We want to scale up. We want to include more fellows in this fellowship program. So this year we had 5. Next year, next cohort, we'd like to have 15, and the year after that we'd like to have 30, and we'd like to keep growing it that way. And we're looking at more sustainable funding models. We'd want to have multi-year funding for this project. And ultimately, the real question we have to ask ourselves is what is needed only capacity building, or do we need more than that? Do we need resource building? Do we need infrastructure building? And I believe it's both. We do need capacity building. We do need to have trained personnel on how to conduct research in all levels, at the frontline health worker level and at the administrative systems level. So people working in administrations should have also this capability. And but ultimately, what really needs to happen is that more resources need to be allocated to LMICs to be able to grow their research infrastructure. Thank you. I'll be happy to take some questions if we have time.
Thank you very much, Tariq. So you really hit the nail on the head with many of the points that you mentioned. So just for the sake of time, we're going to take a couple of questions from everyone here. So let me just look through the chat box. So we have a question from Gurpreet. I hope I pronounced that right. And they ask, would you speak about the challenge of internet shutdowns in both accessing and disseminating research. Between parentheses, Access Now's report released yesterday, 29 internet shutdowns or slowdowns in conflict regions. So do you have any thoughts on that?
Sure. I mean, I can't speak specifically about internet shutdowns and how that's impacted research, but I would connect it to kind of the structural challenges that researchers face in LMICs. So by internet shutdowns, I assume what is meant by that is when kind of the government shuts down the internet to limit the population's access to information. And I think this is really reflective of the nature of government in LMICs. So a major challenge that our researchers faced is kind of lack of transparency that governments are defined by in our region. Many of our fellows work in challenging circumstances with high government surveillance, to kind of put it in blunt terms. So it's sometimes risky to ask certain questions or to research certain subjects. You know, as depending on how you ask or who you ask can either get you what you need or can get you arrested or fired from your position. This is really, unfortunately, the reality of research in some of our regions. So internet shutdown in general limits people's access to knowledge and information and ability to disseminate knowledge. So this, of course, impacts researchers. And I think it should be really connected to the general lack of transparency and openness in terms of access to information throughout the region.
Okay, thanks, Tariq. So we have two more questions. One of them is a very short one, and the other one is a bit more extensive. So we start with the first one. We have Flora asks, how many fellows do you support each year?
So this was our pilot year. So we had in our pilot cohort 5 fellows. We were supposed to have 7, but like I mentioned, one was denied permission to travel by the Israeli occupation, and another was not able to attend because of the sanctions imposed on Syria and Syrian government institutions, because he worked for a Syrian government hospital. He was a physician, a doctor, so he was not allowed to. But this year we had 5. Next year we hope to have 15. And we plan to grow it year by year.
Okay, so our final question for this segment comes from Reem, and she asks a very important question. A strength of AUB, many international partner institutions, many of which are in high-income countries. In light of your comment around centering local research priorities and moving away from research in LMICs as being extractive, how can high-income institutions from high-income countries do better in that regard while maintaining partnerships?
Yeah, so, you know, the danger with talking about these issues as structural issues is that it can seem that, you know, we are powerless in the face of these structures, and until these structures change, which could take decades, there's really nothing we can do. But that's not what I'm trying to say here. I'm trying to say is that we have to keep in the back of our mind that these are structural issues, that there are structural inequalities across the world. There is a structural power imbalance between institutions and academics in high-income countries and researchers and institutions in lower-income countries. So to keep that in mind, to always be cognizant and to acknowledge that fact is number one. And number two, there are basic things that we can do. We can encourage the researchers who are working in the field and actually collecting the data and doing the work, they should, for example, retain first authorship. That's something that my colleague Rania Mansour touched on, is that although I forgot the particular statistics, that a high percentage of the research is conducted in LMICs, but the corresponding or the first authors are lower percentage. That needs to be changed. The ones who are actually in the field and doing the research and doing the work should be given first authorship. And this is something that we're striving to do in CRU. So we want to have all our CRU fellows be the first authors on all of the papers that they publish. And we want to center them and want to have them speak at conferences and publish and grow their potential, their professional development by connecting them to mentors and exposing them to networks of researchers and academics working in similar fields. This is some things that that can be done, and it's not difficult for high-income country researchers to not be extractive, because it's what needs to be done is really a matter of ethics. So if you're coming and you're just extracting data and you're advancing your career and you're profiting off of this research, you're really exploiting this setting and the subject of your research. This is a form of exploitation. So it really comes down to ethics. So strengthening this ethical approach or understanding in high-income country institutions, I think, is one way to reduce this problem.
Okay, thank you very much, Tariq. We have, I think, 2 more questions, but I'm sorry, we're not going to be able to address them. Catherine says, thank you for the fantastic presentation, Tariq, and for your valuable insight on a variety of complex topics. I really appreciate your message of advocacy regarding the importance of being cognizant of the systems we work within and our ability to influence, empower positive change from the inside. Yeah, great point, Catherine. Okay, so thanks again, Tariq. We will now move to our next speaker, who's Dr. Reem. Obviously, we have the pleasure to have you with us, Dr. Reem. Dr. Reem Abu Shumar is a Palestinian CRU fellow from Gaza, who is working as a public health expert with the Palestinian Water Authority. She holds a master's degree in public health from Al-Quds University in Jerusalem, and she is currently a PhD candidate. She has professional experience in managing research projects implemented by multidisciplinary teams and coordinated with multiple stakeholders. Her working experience involved national and international organizations working in public health, water, sanitation, and hygiene. So, Dr. Noor, it's a pleasure to have you with us. The floor is yours.
Thanks, Hadi, for that introduction, and it's my pleasure to be participate in this session panel. I'll be sharing my screen now, and please let me know if you can see the slides.
Yeah, Dr. Reem, just a quick reminder. We can't see the slide, yes, but just a quick reminder that we have to move to the next panel in the next 30 minutes. So
okay.
If you can take up to 20-25 minutes at most, please.
Okay, thank you. So I'll be speaking about research in protected conflict setting, focusing on my experience or reflecting on my experience with the CRU fellowship. I'll start by, I'm trying to move to the next slide, but I think I have a problem. Yes. So I'll start by speaking about my experience with the crew, focusing on the most interesting things that I found from my perspective. And then I'll speak about the challenges. Then I will share some thoughts on how to turn those challenges into opportunities. And finally, I'll share some recommendations for the small research projects and for macro level. So my experience with the crew fellowship, it was an interesting experience. What I like most is that it applies conflict sensitive global health concept for the learning modules and for the course to implement research in the affected zones. It provided on-campus training or courses that was presented by knowledgeable instructors who apply interactive learning approach through presenting case studies and showing role playing for example, for the qualitative research. And in addition to that, the learning modules were designed to build the capacity of researchers, not only in research skills through providing training on qualitative, quantitative, and data analysis, but also it provided a kind of basic scientific background for a selected team. For 2020 year, the selected team was about antimicrobial resistance, and the provided module contained a basic course on the definition, for example, of antimicrobial resistant and how it is diagnosed through laboratory, and if there is case studies in the regions that relate to the conflict setting. The crew also modules and courses focused on very important things about the ethical and security implications in the conflict setting. And it also provided a platform for sharing experience and information with instructors, with the mentor, and also with the fellows who came from diverse backgrounds. They were from a health background. There were somebody who was from engineering background. So it was a chance to share information and to listen from fellows who came from different conflict settings, from Syria, from Yemen, from Sudan, and I was from Palestine at that time. So the crew fellowship also provided mentoring throughout the research process. For me, Dr. Ola Abbara, she was very experienced mentoring on the antimicrobial resistant theme. And she was following with me through the research journey. Moving to the challenge part, which can be categorized into three main categories. The first related to the unstable and fragile setting in the conflict zone. The second is about the COVID-19 declared emergency status. And the third related to the financial resources. Back to the first main challenge, which is related to the unstable and fragile setting, which can be manifested as either a political instability. In my settings, for example, the imposed siege for more than 14 years, the recurrent wars. They are an example of the existing or existing fragility in the war zone settings or the conflict settings. The human vulnerability, and it could be related to this deteriorated socioeconomic situation. It adds also to the fragility of the context. One additional thing is also about the power supply and electrical current deficiency, which sometimes go out for more than 8 hours. And what is the implication of those challenges on the research, and how to avoid the negative impact on the research process? From my perspective, I would suggest, for example, that the context need to be on setting, or is knowledgeable about the researcher need to keep assessing the feasibility of his or her work in a continuous way. So if the activity seems to be unfeasible, he can, or she, or the researcher can reconsider the changing the activity, or have alternative options to continue with his research. Also, in conflict setting, there should be a focus to maintain the ethical consideration and to keep the security of research team as a priority. One more thing is about the instability of the context. Require the researcher to be ready and flexible to adapt any change in the research environment. The researcher needs also to understand the complexity of getting permits or ethical clearance within the conflict settings. The process might be frustrating and lengthy, but we need to move and not to give up easily. The next challenge, which is related to the COVID-19 emerged or declared emergency status, would be manifested as the recurrent lockdown and the self-quarantine. Myself, I went into self-quarantine for 3 times during the last year. Either because when I returned back to my home country, and also when I had contact with positive cases. So we need to consider those challenges while planning or while implementing the research study or activities. Also, the COVID-19 emergency situation put another additional burden on the already overwhelmed health system in the conflict setting in my country. In addition to the emerged need for the personal protective equipment, which I think we managed to solve or to go through those challenges via having a being very flexible when it comes to rescheduling and planning for activities, either postponing some activities till the easing of restriction, or sometimes through proponing some activities, because we have heard that, for example, if I'm planning to implement an activity in a hospital, which is expected to be announced as a COVID-19 treatment hospital, so it will be and not available, and it will be closed, and as a researcher will not be able to access this hospital. So when we have heard about this issue, we propose the activity and do it in advance before it's planned the time. Another consideration was the replacing of face-to-face meetings to comply with the physical distancing instruction during the COVID-19 time. So we have tried to replace the face-to-face meeting by virtual meetings to follow on activities, to agree on the results, and to also discuss the interpretation of the results. Back to the financial resources as a challenge, I think it was one of the major challenges which personally I have faced, because the allocated budget to the Crew Fellowship was very limited, very small. So it was a challenge, but we managed to have a co-funding from WASH and IMR network. And I would encourage researchers to try to have a kind of co-funding from academic networks and other interested parties, if they can also have a kind of interested private donor or any interested party to help with the co-funding. In addition, that for the research topics usually considered as a low priority during the conflict time, because the priority is given usually to the humanitarian intervention rather than doing research. So for the recommendation at a project or study level, I think that from my perspective, we should at the first acknowledge that there is challenges. We shouldn't ignore them, because it can turn into serious consequences if we ignore the already existing challenges. We need to understand the context and how it affects the research in order to develop alternative or contingency plans or alternative scenarios to deal with any emerging situation that could be anticipated. We need to be, as a researcher, flexible when working with research in conflict setting, to adapt, to be able to adapt to the changes in the context. At macro level, I think there is a serious need to utilize the research results for evidence-based decisions in a humanitarian context that can be used for long-term sustainable or development solutions that address the root causes of the problems or that have been addressed by the research. We need to have a more enabling ecosystem for the research, which include flexible procurement modalities, because at conflict times, it would be difficult, for example, to go through sophisticated procurement modalities to procure, for example, lab supplies or equipment. I think also the need to have a fast track for ethical clearance procedures to save time and to help with encouraging researchers to conduct their research within the conflict setting. We need also to incorporate or to consider innovative technology for laboratories so that rapid testing on field can be done on an easy way that will help with having more feasible and convenient research. I think I have finished, so over to you, Hadi. Can you hear me? Hadi?
Yes, I can. Thank you very much, Reem, for
You are welcome.
yes, thank you much for sharing your valuable experience with us as part of your group fellowship program. So we will take the next few minutes for the Q&A. So please feel free to type your comments in the box, and again, I will relay them to Dr. Reem. Okay, so we have a comment from Amit from NIH. And they ask, what was the most important research skill you gained from the Crew Fellowship?
Okay, can you hear me?
Yes.
Yeah. The most important skill that I gained from the Crew Fellowship was the research skill related to the qualitative research, the qualitative research methodology, and how it can be applied for conflict settings. In addition to the skill of sharing information and particularly with fellows and researchers from the same conflict setting.
Okay. Thank you, Reem. Okay, so if there are no questions left, we can move to a small break before we start with panel number 2. So if you can just wait a couple of minutes to see if there are any questions remaining. Okay, it doesn't seem like there are any questions. So, okay, so thank you everyone. Thank you our speakers, Rania, Tariq, Dr. Reem. Thank you for all the work that you've done preparing for this. It's much appreciated. So now we will take a 9-minute break for our next panel. And panel 2 will start at 7 p.m. Beirut time. Okay.
Thanks. Thank you.
Hello again, everyone. So welcome again to our session on approaching health research in conflict settings as part of the CUGH conference. So we've had our first panel already, and we heard from 3 speakers so far that presented some of the work that's being conducted under CRU. And now we will move on to our second panel. So we'll have 2 speakers, Dr. Fuad and Dr. Saleh, who will discuss the political economy of health in conflict settings, and they will introduce their special issue on this topic that's currently being led by GHI, co-led by the Research for Health in Conflict, so R4HC working group, and that will be published by the Journal of Global Health. So without further ado, I'm happy to introduce our first speaker. Dr. Fuad is an associate professor of public health practice at the Faculty of Health and Sciences at AUB, and the co-director of the Refugee Health Program at the Global Health Institute. His research currently focuses on the forced displaced populations, with a special interest in the Syrian refugee crisis, as well as the impact of this crisis on the health and well-being of the Syrian population. Dr. Fuad is also principal investigator and co-investigator on several projects related to health in protracted and armed conflicts. He served as a commissioner in 2 Lancet commissions, so the AUB Lancet Commission on Syria and the Crises in Global Governance, Health and Aid, and the UCL Lancet Commission on Migration and Health. Dr. Fuad is author of more than 70 peer-reviewed articles, op-eds, and reports published in top journals, including the Lancet, PLOS, BMJ, Conflict and Health, SSNM, and NYT. He is currently the country principal investigator of a project on health system research in fragile and shock-prone settings. And he leads the political economy of health and conflict workstream and the GCRF funded project called the Research for Health and Conflict, R4HC MENA, developing capability, partnerships, and research in the Middle and Near East. So we're very happy to have you with us, Dr. Fuad. The floor is yours.
Thank you, Hadi. It's a long introduction, but thank you, very nice. And thank you for inviting me to speak in such a very distinguished setting and conference. So could you please share the presentation? Or should I do it from my side?
You are given access to share it. It's easier if you do. If you want me, I can take care of it.
You know what? They told me that's difficult. So please, can you share it from your side? Unless let me do it from my side. It's fine. Okay, I hope I do it the right way. I think this is the right one. Okay. You see my screen?
Yes, very well.
Okay, thank you. So, the presentation today will be like in two parts. I will present something about the some theoretical approach about the political economy of health in conflict, and that will be followed by Dr. Saleh to present about our special issue on the political economy of health in fragile settings. As Hadi mentioned, this is part of our partnership with R4HC MENA program project, which is this is about building capacity and doing research in humanitarian and conflict settings. Specifically, this program focus on 4 countries in Middle East, Lebanon, Gaza, Jordan, and Turkey. And I have this privilege to lead the work stream of political economy of health in conflict settings. So to start with, I will have these couple slides on defining the issue of what do we mean by political economy and how that can be applied to health, and then in specific on health in conflict. So political economy, as many of you know, that can be defined as sort of both, study both politics and economics and the interaction between these two domains. And it focused mainly on the issue of power and resources and how these power and resources are distributed and contested in different countries and sector context, and what are the resulting implications for development outcomes. From the perspective of analysis, as a tool for the political economy, actually it supports the issue of policy process in 3 different ways, or 3 equal ways. One is about generates assessment of the political landscape, including, mapping the stakeholders and the political actors. And the second is about the assessment of the power and the position of these actors, in addition to the estimate of political feasibility for the policy change. The second way of supporting the policy process is to focus the attention on how the political strategies in general shape the issue of policy reform. And this is important when thinking about when we will apply that on the issue of health and health service. The third way to in supporting this process is that this analysis, the political economy analysis, underlines the role of different political economy factors through this cycle of policy cycle, including how to set the agenda, how to design the policy, and the issue of adoption and implementation and evaluation. Well, how that concept can be applied on a health in conflict, on a health in general, but also on a health in conflict is specific. So in health sector, this the knowledge about politics, powers, and the political analysis can be a very strong tool to improve the effectiveness of the policy process. And as many of you know, that this is something usually ignored in the discourse about the issue of understanding the health process and healthcare actually system in a specific setting, let alone settings in conflict that the element of the of politics and powers are important. And that leads to issue of the question. The main question in this regard is how the decision is made in specific settings. So that the political economy analysis give us a strong tool to understand and even explain and and even later design how the health decision actually is made in the context. The third issue in this regard is to promote evidence-based analysis, and that can this one can assist the policymakers to move toward the universal health coverage and the health-related SDG. And usually, when talking about the political economy of health in conflict settings, we have this issue of the other element that can play the role or interact with that, which is the traditional elements or determinants about social and economic process. From the perspective of actors, so we know that a range of actors, including individuals or organizations, influence this process in a way that they determine how the policies are introduced and implemented. And in a crisis affected settings, where we have a sort of dramatic change, not just in a specific period of time, but sometimes that can change over time, and that can sometimes last long, which we see it now in many parts of the world. Given, for example, that in late 80s, the estimate of the length of conflict, crisis, or the consequences of conflict crisis, like a displacement, the average length at that time was around issue of 7 to 8 years. Now we're talking about 19 years. That and the examples from Afghanistan, Somalia, Iraq, and DRC, and recently now we're talking about Syria and Yemen, that last long times, and then the elements of the politics and political economy play a major role on that. So the search or the research on political economy influence provide, in fact, sort of insight in this regard to examine this sort of interaction between different actors, different interests, and the impact on the socio-economic policies and outcomes. So what are the key elements in the response to health in a crisis from this perspective, from the perspective of political economy? This includes actually a sort of more understanding or look into the issue of opportunities and challenges, presented by crisis. We know that there are many challenges when talking about providing a healthcare for displaced population and host communities during crises or during armed conflict. The lens or the perspective or the analysis from the perspective of political economy can give us more understanding on the different opportunities, and that can be brought by the crisis itself, but also how the sort of provide us with lessons about what is or what are the best utilized approach to promote investment in the health system. Coming back to our project that I mentioned at the beginning, which is R4HC, MENA, which is the overall umbrella that have different work streams, including, political economy of health in conflict settings. This is a program that focuses, as I mentioned, in these 4 settings, and the main aim is to provide systematic and empirically grounded research capacity in the political economy of health in regard to the conflict in MENA region, and focus particularly on specific objectives about, developing methods to examine this sort of historical development and policy of the research system in these settings, and what is the current role of government, private sector, and international donors in shaping the humanitarian health system. What we did actually is we worked on the first deliverable, the first outcome. Unfortunately, I missed to put the report, or at least the cover of the report, but we were able to deliver a report on the political economy of health in Lebanon, and that will be followed by the other 3 countries. And in this report, the political economy of health in Lebanon, we tried to show the, I quote here, the health and well-being of a nation, which is Lebanon, that cut across sectarian and political boundaries. They are highly sensitive political issue, as we tried to show. The policy and political structure of the Lebanese health and social welfare system, how that we showed that how that have sort of strong impact and effect on the healthcare of the beneficiaries, including the refugees, displaced population, and host communities. And in fact, this product that we developed showed how, since the civil war, the Lebanese civil war in between 75 and 90, since then, how that factors of the political economy factors played a major role, and we traced the impact of different actors, whether they are local actors or international actors that shape the system that we are lived in now. But also we tried to see that what happened next, given the economic crisis, the COVID crisis, and the Beirut blast that happened in August 4th, 2020, how these accumulative, different layers of crises were already, affected by these pre-existing, factors that played a major role in the system and the Lebanese health system. We will be happy. I will put the link in the chat box on this report, and we will be happy that you can, if you can, read it, and you can send us your comments on that. I will stop here and hand it to Dr. Shadi Saleh on the special issue on political economy of health. Dr. Shadi.
Thank you, Dr. Fuad. It's a pleasure to be at CUGH once again. Definitely, this is a forum for global health that I always have the pleasure to be a part of. So Dr. Fuad presented to you basically a little bit of background on political economy of health in general and how relevant it is to many parts in the world, especially in low and middle income countries. I think that based on that premise, we made a proposal and a decision to present as the Global Health Institute at the American University of Beirut in partnership with the Research for Health and Conflict, MENA, to present a proposal for a special issue on that topic. So the topic of political economy of health with a special focus in the developing world. And when we when we talked about the developing world, our emphasis was basically on the global south, especially areas that have been conflict-ridden. The reason why such a special issue is of relevance is because these settings, these contexts, are contexts where there's quite a bit of input that political economy analysis can contribute to the health policymaking process. So without further ado, let me talk to you a little bit about that special issue. The special issue is or will be in the Journal of Global Health, and specifically it focuses on three main areas. The first is theoretical work and political economy of health. The second is trying to focus on contributions from the states that are affected by either short-term or long-term impacts of conflicts. Now, there are few areas of focus for that special issue, specifically 5. The first is, as you said, the theoretical and conceptual overview, particularly the intersection between political economy and public policy making, and navigating healthcare through the lens of political economy. The second is, I think, is rather important, that, and many many researchers in the global south find it a little bit challenging from a methodological standpoint to be able to conduct political economy studies, especially when we have protracted crises where data collection or available data sets are limited. The third is a comparative look at political economy, and that can take both lenses. The first lens is looking at different settings within the global south and seeing how political economy affected the health policy making process or describe it. And a second approach to that comparative political economy analysis is between cases in the global south and others in the global north. Continuing on, we are also very interested in case studies in political economy analysis, and we have received, I think, few submissions that take one specific setting, one specific country, and go a little bit in depth into that, and those were interesting to read and definitely will be considered. And lastly, it's looking at the complexity of healthcare in developing and conflict-ridden countries, because as we know, in those settings, the humanitarian aspect that usually starts with an emergency sort of approach or a humanitarian emergent approach, and then moves on as those crises are protracted. And we've seen it in many parts of the world. Definitely there's a specific or an interesting angle that political economy can contribute, because it doesn't, in those instances, it does not only involve one country, it involves the original country, where the conflict has started, then it affects or engages host countries, that may be many, and also there are multiple players, whether it is the health systems in those countries and the host countries, NGOs, INGOs, and the whole UN system. So definitely there's much to write, there's much to read and reflect on. Moving on, there are few challenges and things to consider in general when we're talking about political economy of health in these settings. Now, the first bullet talks a little bit about the MENA region because of two reasons. Simply because we are focused as an institute and as a project in this region, but secondly, because the MENA region has been the epicenter of humanitarian crises, I would argue, for the past 70 years, nonstop. The second is the discipline of political economy in general has not been explored as a lens to look at health policy making, especially when we have a range of interests, incentives. The region or in general, any region in the global south has certain cultural, demographic, and social sensitivities. All of these do shape policy making. And another interesting angle is how those sort of political economy inputs shift over time with different political regimes, with sometimes revolutions, conflicts, and so on and so forth. Moving on, another set of challenges to consider is the whole issue of coordination in these settings, conflict-ridden settings. It's many who are involved in this tell you that even in protracted crises that have lasted multiple years, there's always issues or challenges of coordination, challenges of who funds what at what level, and as a result of coordination and funding, who has political control. This is extremely interesting and extremely under-examined because in reality it affects planning, financing, the whole policy-making process, as well as implementation. So there's a major need to understand those dynamics, to dissect them, and to present them as well. Next, please. So as I mentioned earlier, the difference between looking at political economy of health in sort of normal settings versus when we have settings where there are crises or conflicts or the states are fragile, is that in normal settings, the number of players, or I should say powerful actors, people who can really make a difference, are few. Compared to when you're looking at the political economy of health in a setting where you have so many active actors, both at the national, regional, as well as international level. And basically, we have seen it in many parts of the world where, and many examples may come to your mind, to my mind, if we're talking about Colombia versus Venezuela, if we're talking about Bangladesh in recent years, and DRC in Congo, as well as in our region. Those different actors that are beyond national actors really shape national health agenda. So this doesn't only affect the current health agenda, but also it shapes social protection systems, and in reality, the face of all of the sort of access to health within those countries or within those regions. Next, please. I think this is the one of the last slides specifically discussing why do health systems in low and middle income countries, mostly in the global south, as well as in conflict-ridden countries, why would political economy of health be important? And simply because these countries face significant health challenges. Many think that the non-communicable disease burden is significant in the global north. Actually, the problem in the global south is that there's a double burden of disease, including non-communicable and infectious diseases. So NCDs are not a problem of the global north. It's a problem of global south as well, that as increasingly important because the infrastructure is not there, unlike in the global north. The second is, with those conflict-affected countries, there's an increased mental health burden. We are seeing this in our region and the studies that we're conducted. So this is a significant burden. Number 3 and 4 are somewhat related in the sense that because of the limited resources to be invested in healthcare and the cost constraints, there are limited access to resources. And in addition, the able healthcare workforce who can move on, migrate from those regions, do migrate, which means that whoever is left is either not as able or not enough. A huge issue. We've seen that in Iraq, for example. In Iraq, in the years following the Gulf War and the second Gulf War, the percentage of healthcare professionals who left Iraq is significant, leaving a big gap in the ability of the country to deal with its health problems. Bullet number 5 is that in those settings, there are multiple stakeholders, development partners who come to these countries with the purpose of helping, which they do, and perhaps they mean well. However, the way that they affect the system in many instances create, on the long run, further complexities. And this is also in bullet number 6, which is the penetration of all of those actors and how is that affecting the health policy making. So all of these points that I've mentioned are important points for us, or were important points for us when we decided to issue that call for papers. It's important to mention that the call for papers is still open. I would like and encourage for all of you to spread the word out that we are still accepting submissions, and I think we are I believe early summer we're closing that call for papers. So I do hope that whether it's you or your networks would be interested in submitting of papers to this very important special issue. I would like to thank you all for staying with us and hope that we stay in touch.
Thank you very much. Yes, thank you very much, Dr. Saleh, and thank you, Dr. Fuad, for your presentations. So we will open the floor for questions now. So please feel free to just write them in the box here, and I'll relay them to the speakers.
Hadi, just if you allow me just to add one point is that I put the link to the report on the chat box. You can download it. Anyone can download it, and and also Dr. Adam CUGH mentioned also in the co-author of this report, and Dr. Sharif Ismail also, and others. Dr. CUGH mentioned to the issue of that this also report updated and to include the mental health and the recent events in Lebanon. So please check the link and let us see your comments on that. Thank you all.
Okay, so we have a question from Catherine. Okay, so I'm sorry, just a second. Okay, so we have Catherine saying, thank you, Dr. Fuad and Dr. Saleh for the great presentation. What are some ways you feel we may be able to engage humanitarian actors, agencies, and local healthcare facilities, healthcare workers in improved coordination of activities, including resource allocation? Another question also from Catherine is, in addition, how may we be able to improve support for the healthcare providers working, healthcare providers workers continuing to work on the ground?
Dr. Shadi, will you take care of part of it, and then I can continue something?
Sure. So I think the focus of Catherine's question on specifically healthcare providers in those settings. And I have to say that it's quite challenging for them on multiple levels. The first level is obviously the issue of security, being in a conflict-ridden setting. The second issue is economical, especially being most of those settings tend to be resource poor. And then the third setting, which has been there since 2019, which is COVID-19. So definitely, these are three major burdens of healthcare providers. Now, in terms of support, I'll tell you what has been happening historically, and then perhaps Dr. Fuad can build on that or contribute other ideas. What has been happening is that those healthcare providers have been supported, in most settings, supported to a certain extent through the resources that were invested by either development partners, donors, NGOs, to either directly to them or to the institutions that they serve. Still, the question is, does that resource investment, is it reaching the individual? And that's what's important. So this is the bigger question. And the answer is not in all instances. And the second is, what will happen on the longer run when you have that donor fatigue? And we've seen that in the Syrian crisis that has been happening, or that has been going on now for 10 years, started in 2018, we are in 2021. We are obviously seeing donor fatigue, which means that the host countries that are already limited in resources having to share more of the burden and affecting its own healthcare system. So definitely this is an important point. And from a system standpoint, the intervention has to be global, because the country itself, countries themselves do not have the resources to, unfortunately, to support this important group or element of the healthcare system. Dr. Fuad.
Thank you, Dr. Saleh. Just to build on that, but also to mention to this word, Catherine, you mentioned in your question, which is coordination. I think, this is something that we used to talk about it. We used to, to try to support this issue of coordination, but to tell, since, my work in this field of a humanitarian, that is one of the most difficult part, because of many issues, including, or maybe on the top, is the competing on funding, the competing on the issue of interest. And that's why we see in many cases with sort of overlapping on one side, but also huge gap on other side. And that leads to this issue of research fatigue, when different actors, including international organizations, moving, to say it from that way, from one crisis to another, because we see now in the last 2 or 3 decades, as I mentioned, this sort of lengthy, protracted, long-term crises that put these challenges, of continuity in terms of, human resources, fund, and also interest. Let alone that's in the last year when we have this sort of COVID as something that absorbed more of the, not just the interest, but also the fund of that. And we see now this shortage in funding from the US, UK and Europe in addressing the issue. How to improve that? I think by shifting this approach from addressing humanitarian, crises into more what's called now humanitarian development nexus. We see that in sort of broader approach as development approach more than just filling gaps or addressing basic needs. Over to you.
Thank you, Dr. Fuad. So we still have another question from Adam. The question is, why should policy decision makers engage with academics about these issues when most academic research on humanitarian issues is out of date by the time it is published? How can the relationship between academics, researchers, and policy be improved?
So I can perhaps also start by addressing this. I think Adam is definitely on target with this. There has to be a quicker engagement between academic output and policy making. However, this is a two-way street, and this is why political economy becomes important. If you look in reality, if you look at traditional health services research, Adam's point is definitely very relevant, because from the time you start data collection to the time you publish a manuscript, basically you'll have 2 to 3 years. By that time, things have passed. Whereas a field such as political economy is a field that doesn't look at things that are extremely acute. Rather, it tries to look at systematic issues within the realm of political economy that affects health systems and health policy making. And these tend to lend themselves to longer term planning, which is in favor of political economy analysis. But definitely with respect to health services research, there's a need to develop, quicker products for policy making, and policymakers, very few of them, look at evidence and conceive that as part of the inputs into policy making. Rather, it's more of the politics, and hence, again, the relevance of the field of political economy. Over.
Yeah, I cannot agree more, with Dr. Saleh, and I think that's why when talking about political economy approach or analysis, to see it from the more comprehensive, a holistic approach than, more technical part. And when seeing, the issue of, from the changing, environment more than statistic event, then we can, examine even the response, not just the academic. Academic is one element, but also all these issues of process of, the system itself, the humanitarian system itself, in responding to crises. And mainly, the response is a sort of a short term, response on, only on the, first, say, period of shock. Whereas, when we have this protracted long term, then the response will become like a very, very slow. So I think that's why we are producing now, or introducing now, this issue of concept about the political economy approach for health in conflict. Over.
Thank you, Dr. Fuad. It seems we have another question from Nalini. So Nalini asks, can you provide a specific example of a health challenge that has been or could be addressed through an understanding of the political economy leading to health policy or health system change?
So actually, there are multiple examples. You know, the whole revision. So I'll give you two concrete examples. The first example is the revision of social security systems in many countries, especially in the global south, was directly affected by political economy contexts, even without a formal political economy analysis. So this is one example. The second example from conflict-ridden settings is the emerging healthcare system structure that comes out as a result of multiple stakeholders, national, regional, and international, playing a humanitarian role in a healthcare system. So these are concrete. For the example is, you know, Lebanon definitely is an example, the country that we live in. Definitely the role that the humanitarian sector and development sector have played in the past 10 years are shaping, you know, the healthcare system informally, but they are shaping that. So these are two concrete examples on how, you know, the political economy sort of, although informally examined, have an effect on health systems.
Nalini, thank you. I really invite you to read our report about political economy of health in Lebanon, and the following report that will come on in the coming, hopefully, months about the other settings in the region. It's a sort of a serious try to understand or to offer different tools to understand the factors that usually are ignored in understanding healthcare. Therefore, that could be very useful when thinking about how the coming step, sort of the recommendation will be built. The recommendations will be built on a sort of more in-depth understanding than just addressing what's called the humanitarian needs. So maybe we, in this research and this attempt, try to have this answer about your, and maybe Lebanon is one answer as mentioned by Dr. Saleh.
Okay, so thank you, Dr. Fuad and Dr. Saleh. It seems like there aren't any more questions. So it might be a good time to wrap it up as we're approaching the end of the panel. I want to thank you all, to all our speakers today and all the attendees for joining. And of course, I want to thank the CUGH group for coordinating this. It's been a pleasure taking part in this event, and hopefully we'll see you all again next year.